Good evening, sir.
Good evening, Singh, sir. Good evening, Ailersi Madam, Revati Raj, Anurag.
Good evening, sir.
Good
evening,
evening. How are
Revati,
you? Yeah, nice meeting you after a long time.
Sir, good evening, sir.
Good evening. Boss.
Good evening. Good evening.
Good evening.
Sir, good evening, sir. Srinivasan, sir. Good evening,
Good
sir.
evening. Good evening.
Let us wait for some few minutes for others.
Just to join.
3-4 minutes. Meanwhile, I'll go live on YouTube and come back.
Okay, sure.
Good evening, Ailersi Madam, Revati Raj, Anurag.
Good evening, sir.
Raghav, can you check once by sharing your screen?
Yes, sir.
Will you be able
Am I audible, sir?
Hi, you are audible.
Okay, sir.
Can you put it in full screen mode?
Sir. One second, sir.
There downside.
Sir, it's not.
Right side. Now, fourth icon.
Yes, sir. Yes, sir.
Yeah. Okay. You can minimize. Same icon.
Is it fine, sir?
Yeah, you can minimize that.
No, sir. I'm not able to minimize.
You can hit the escape in your laptop.
No, sir.
Yeah. One more time, you can minimize.
No,
Here.
sir. Yes, sir.
Can you unmute and say unmute?
Is it fine, sir?
Ailersi, madam, can you hear us? Forget madam.
Good evening, Prasanna.
Good evening,
Sir.
sir. Good evening,
Sir, good evening, sir. SPS, sir, good evening.
Good evening, Somasundaram.
Good evening, sir. Good evening, sir.
Good evening, SBS sir. Good evening, Som.
Oh, good evening,
Sir, good
Sinkaradu.
evening,
Sorry,
sir.
I missed.
Welcome. Welcome, sir.
Sinkaradu.
Oh,
Good
okay.
evening, Dr. Elarasi.
Madam, good evening, madam.
Raghav, you can stop sharing. Okay.
Sir?
You can stop sharing. After that, you can.
Okay, sir.
Good evening, Dr. Bala,
Good evening, sir.
my
Okay, sir.
teacher.
From US, Srinivasan, sir.
Sir is always online, sir.
He'll be online.
Learning is a continuous process, especially with such great teachers. It is a good evening, Dr. Somasundaram.
Sir, good evening, sir. Sir, welcome to
evening.
our PG
Yeah.
teaching Gurukulam,
Thank
sir.
you,
Welcome,
thank you,
sir.
thank
Welcome,
you,
sir.
thank you. Yeah.
There was some technical glitch for ALS, madam. Madam, can you hear us, madam?
I can hear you now, President.
Yes, madam. Shall we start, sir?
Good evening, Elarasi madam. Good evening, madam.
Good evening, sir. How are you, sir?
Fine, madam. Fine.
Shall we start, sir?
Yeah.
Okay, sir. Once again, check with the Revati Raj, madam. Madam, can we start, madam?
Absolutely. I'm all set.
Madam,
Yes.
good evening, madam. Revati, madam, good evening.
Good evening. Good evening.
Good evening, Dr. Raj and Dr. Elarasi.
Good evening, sir.
Okay.
Good evening, sir.
At this outset, I welcome you all for this fourth edition of a virtual Gurukulam organized by IAP CCB, a favorite among the postgraduates. This week being primary immunodeficiency week, we thought we will include a case of immunodeficiency under hematology. So today, for this meet, we have two eminent gurus. One, Dr. Revati Raj, Madam is a senior consultant, pediatric hematology and oncology division, Apollo Cancer Center, Chennai. She is a MRCP and a fellow of Royal College of Pathology. And she's one of the pioneers in bone marrow transplantation in pediatrics, Chennai. And another mentor, Dr. Elarasi Madam, a proud alumni of KKCDH. Senior Consultant and Pediatric Hematologist, Rainbow Children's Hospital, Anna Nagar, former IAP President, previous consultant in Mehta Hospital. I welcome you both, madam. Also, I welcome this pivot of this program, Dr. SBS sir, the Guru of Gurus. I also welcome Dr. Singarvelu sir, National Vice President. And I also welcome Dr. Srinivasan sir, another Guru of Gurus for all of us. I welcome Dr. Somasundaram sir, IAP CCB President, Chennai City Branch President. Also, we have Dr. Ramya Upluri in this meet. She is a consultant pediatric hematologist and a BMT physician from Apollo Children's Hospital. And I also welcome Dr. Anurag, Associate Consultant Apollo, who is with Dr. Revati Raj Madam's team. Today's presenter, I welcome Dr. Raghavan, final year postgraduate from ICH MMC. So with this, sir, SB sir, you want to say a few words so that we can start, sir?
Thank you, Prasanna. As part of Dr. Somasundaram's initiative, we are having the fourth session. And more than the students, there are two senior students. One is Professor Srinivasan, the other is me, who are very eager to learn from two distinguished pediatric hematologists, because Dr. Revati Raj and Dr. Ilarsi. I look forward to a very, very interesting and useful session. I'm sure all of us would learn from both of them and the interactions. Over to Prasanna. Thank you very much.
Som Sundaram sir, a few words from you, sir.
So, good evening. At the outset, I thank the Apollo pediatric hematology team for giving this, for coming as a team, and I enlighten the subject of immunodeficiency for our postgraduates, and as I told, this will be useful for our pediatric practitioners also. Thank you, Revati ma'am and your team. And as usual, our conveners, Dr. SBS is there to guide us all through the 12 programs. And our co-faculty, Dr. Elirasi ma'am, she is also an is into hemato-oncology, and ma'am will also be guiding the postgraduates through this session. And we have many teacher of teachers here. Dr. Srinivasan sir, Ponti Srinivasan, Singarvel sir is there, and I can see in the screen lot of pediatric practitioners who have logged in along with the postgraduates. Welcome all for this novel initiative by IAP Chennai City Branch, and we are into the fourth series, and we have another 8 series all the way. And thank you for all the patronage. Thank you. Over to Prasanna.
Yes, sir. Shall we start the proceedings? Raghavan, if you are ready, can we start?
Yes, sir. We can start, sir.
I request both the gurus, they can stop Raghavan at any point, and they can just discuss. I also thank ICH team, Professor Dr. Balamurugan and Dr. Sarath Balaji and Dr. Sajati Begum for guiding Raghavan. You can start.
Good evening, one and all. Myself, Dr. Raghav, final year postgraduate from ICH. I extend my sincere thanks to IAP CCB team for giving me this opportunity to present the case in front of the legend. Herewith I present a child, a 9-year-old girl child, third born of non-consanguineous marriage, with history of fever for 2 weeks, and history of cough for 2 weeks, and history of weight loss. The history of presenting illness: child was apparently normal 2 weeks back, then developed fever for 2 weeks, which was low grade, intermittent, more during the evening, not associated with chills and rigor, and relieved with medication. The child also had cough with expectoration for 2 weeks. The child has loss of weight, approximately 3 kgs in the past 2 months. no history of breathlessness, no history of chest pain, no history of ear pain or discharge or throat pain, no history suggestive of any other focus for fever, no history of bone pain, bleeding manifestations or lethargy. Past history. At 4 months of age, the child had a history of swelling in the left axillary region, for which the child was treated with oral medications for 4 months. Details unknown. The child is not a known case of visa or heart disease and no history of previous admission. Antenatal, natal, and postnatal history was uneventful. The child was developmentally normal with average scholastic performance, and the child is immunized up to age with the BCG scar present.
Uh, can I interrupt Raghav at this point?
Yes, ma'am.
This past history of a swelling in the left axillary region, what do you think it was at 4 months of age? And what do you think would have been the medication?
The swelling in the left axillary region at 4 months of age would probably be an adenopathy, ma'am, BCG adenopathy, for which the child was treated with oral medications for 4 months as per history, ma'am.
What is the present recommendations for treatment of BCG adenitis?
For BCG adenitis, we should look whether it is suppurative or non-suppurative, ma'am. For non-suppurative BCG adenopathy, we can wait and watch. We should keep the child in close follow-up since it may go for suppuration, ma'am. In case of suppurative lymphadenopathy, we should see whether it is thick or thin suppuration. In thin suppuration, we should do repeated aspirations, ma'am. In case of thick suppurations, we should do incision and drainage.
Do you think it was
incision,
ATT for?
What is role for
there
ATT
an
in
indication
this
for
child?
ATT? Okay, yeah.
Shall I continue, ma'am?
Yeah, sure.
The diet history, the child expected weight is 29 kg. The child expected calories is 1680 kilocalories, and the child's intake is 1500 kilocalories, and deficit is 180 kilocalories. For proteins, the expected is 43 grams, and the intake is 30 grams, and deficit is 13 grams, ma'am. Family history. History of father took ATT 10 years back for pulmonary TB, and mother took ATT 1 year back for pulmonary TB. Other siblings normal, ma'am. Socioeconomic history, child lives in a pakka house with 2 rooms with overcrowding, separate kitchen facilities available, separate toilet facilities available, corporation water, and socioeconomic class, lower middle class. The history summary. This is a 9-year-old female child, third born out of non-consanguineous marriage. First 2 siblings normal perinatal transition, no previous admission except for the swelling in left axilla at 4 months of age. Now child presented with fever, cough and cold for 2 weeks with significant weight loss. Family history of pulmonary TB in both the parents and significant contact, and history of overcrowding. Anthropometry. The weight is 19 kg and height is 124 centimeter. BMI is 12.3, which comes under less than third centile. The child is thin. The child is thin and SMR stage 1. This is the IAP growth chart, ma'am. General examination. The child is conscious.
Madam, you have any questions, madam?
Yeah, I want to ask. So you are seeing a lot of patients in your OP, and you see someone with BCG adenitis. What will make you think this is not normal? This is something out of the way. So just to initiate lateral thinking, because what are the things that will make you feel maybe this is not right?
Ma'am, any BCG adenitis with excavator scar, so we should think of immunodeficiency disorders, ma'am. And
Supposing I see a child who's had BCG adenitis, had treatment in infancy, then at 3 years of age has had typhoid, and now at 5 years of age again has had a typhoid. Would that bother you?
Ma'am, this will support us. This will make us to think the diagnosis of MSMD, ma'am, Mendelian susceptibility to mycobacterial diseases, ma'am.
What's the connection between BCG and typhoid?
For both these organisms, the interleukin 12 and interferon gamma are important cytokines for immunity, ma'am. So in MSMD, there is a defect in these immune pathways leading to frequent infections or with these organisms, ma'am.
So, any unusual tuberculosis that you have seen when they've had MSMD? For example, if you see someone, say with one of the kids that I saw had come presented with hypertension, and when we investigated, she had renal artery stenosis, and then that turned out to be because of TB vasculitis. I'm just saying. So
Okay,
the
ma'am.
message is that if they have an unusual site tuberculosis or other infections in their life, or they're not thriving, I think a failure to thrive is something that we always go back to when we are doing pediatrics. So all of this would make you think that maybe there's something out of the way. Yeril, you want to say anything else?
Apart from the other things like other Mycobacterium bovis can cause disseminated infections in these children. And BCG BCG strain very rarely causes disseminated tuberculosis in an immunocompetent child. So BCG strain with disseminated tuberculosis or Mycobacterium bovis causing the unusual, not the usual strains. So that will make us think in terms of. That's why I asked you, why did they give 4 months of therapy at the beginning? When it's not indicated in a immunocompetent child. So what were they thinking of at that time? Somebody has thought of something. So what was the drug? Was it ATT or was it something else? Even if it is just a purulent discharge, secondary infection, why 4 months?
Yes.
So
Sir, yes, sir, you have any questions, sir?
No, I have few comments. One, any BCG adenitis is a red flag,
Okay.
irrespective of the nutritional status of the child at the time of the adenitis, irrespective of anything else. You know, most BCG adenitis is because of subcutaneous administration of the vaccine erroneously. Sometimes they push more also. That's the most common cause. But we can't afford to ignore immunodeficiency. In fact, I am to remind the students here that in the United Kingdom, they have changed their policy of the timing of BCG vaccination. I'm sure Dr. Revati Raj would know more than me. They have now introduced routine screening for primary immunodeficiency. And then only when the reports come at the end of 28 days, only if the screening is negative, they give BCG vaccination in the United Kingdom. This is a recent NHS policy. I don't know when we will advance to that level to do neonatal PID screening and then delaying BCG vaccine, because BCG vaccine in somebody with primary immunodeficiency is a disaster. In fact, it will trouble not only the primary pediatrician, it will also trouble senior hemato-oncologists like Dr. Revati Raj. I'm sure she would agree with me. That's my comment number one. Comment number two, the student said that he will do incision and drainage. That's not done in BCG. Whatever that happens, if there is an abscess, we do only repeated aspiration and not incision and drainage. Incision and drainage in a tuberculous abscess will lead to a sinus which will not heal. It's like any other cold abscess. Cold abscess, we don't do incision and drainage. We do either non-dependent drainage or repeated incision or an excision. So the treatment for refractory BCG adenitis is excision, not incision and drainage. Right? My last comment is, this child, whether you like it or not, there is a strong possibility that this child had some BCG-induced infection maybe. And with history of contact with the parents, there is probably a strong possibility of tuberculosis. And one point you must remember as a primary pediatrician, TB recurrent symptoms in TB are very, very unusual. They occur only in the setting of 4 conditions. One, primary immunodeficiency, as rightly said by you, MSMD, or any other CGD, etc., 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 any cell-mediated immunity defect also. Second is iris. Third is drug resistance emerging later. Fourth is, of course, poor compliance for treatment. And fifth, if you ask me, very common, wrong diagnosis. It may not be tuberculosis, but it will be diagnosed as recurrent tuberculosis. These are my comments. And with this history, you should definitely think of immunodeficiency. Of course, one history you should have provided in your story, whether the parents are HIV positive or any HIV testing had been done for this child. So nowadays, antenatally routine HIV testing is done, but the data must be for it, because you can't afford to miss HIV infection causing BCG abscess as well as tuberculosis now. Thank you.
You rightly said about the newborn screening for SCID in all Western countries these days. So for them, they screen and then give the BCG vaccine. And for us, it's the other way around. Because of the BCG vaccine, we diagnose the babies with SCID, which is very sad because it takes us ages to stabilize their disseminated BCG, and only then we can start their transplant process. So it is something that, as you rightly said, consanguinity is high in southern India. Our rates of immune deficiency are high, and still we are not there with newborn screening yet. Hopefully, with time to come, we will start newborn screening. Yeah. So, as rightly pointed out, there are some infections that would make you think of an immune deficiency. For example, I'll just ask you, if you saw a child with granulomatous adenitis, but 2 times you've done a biopsy and you've not found AFB, what would you think of?
Sorry, ma'am.
I said that a child has come with recurrent lymphadenitis, say neck nodes, and twice you've done the biopsy, and it comes as granulomatous adenitis, but you haven't found AFB, or gene expert has been negative. So what would you think of?
Ma'am, conditions like Kikuchi disease can present, ma'am.
Mm. Okay, that's what Dr. SBS was trying to say about the wrong diagnosis, because chronic granulomatous disease is the one condition. Yeah, you rightly said, somebody's answered in the group, because the infection is the kind of infection is a pointer, because the neutrophils are able to phagocytose the staphylococcus or the bacteria, but they can't do the oxidative burst and digest. So they form granulomatous adenitis. So recurrent TB, as Dr. SBS said, is one of the features that children with chronic granulomatous disease present, because it's not actually TB. And every time they get ATT with rifampicin, which is a really good drug for staphylococcus, and then it resolves, and then again they have. So we have to think of a neutrophil function disorder like CGD when they've said that they've had recurrent tuberculosis. So some infections are hallmarks. So listening to a story itself will help you diagnose this is an immune deficiency. Yeril, you want to take up history in immune deficiency, and then or should I continue this, please?
So, like Revati said, what are the things in the history? Nowadays, I find that not many people take a detailed history. Detailed history gives you halfway through your diagnosis. Then you consolidate with your investigation, clinical examination, and your investigation. So the recurrent, there are some criteria, certain conditions when you think of probable immune deficiency, like you have a recurrent ENT infections, which is more than 4 in a year. Okay, you have a severe sinus infections, 2 or more in a year. Then you have 2 or more pneumonias in a year, or you have deep-seated infections, 2 or more in a year, or if there is, as I said, family history of early infantile deaths, or early deaths due to some severe infections. And if it is, as Revati said, infections with atypical pathogens, these are ones that should put you on high alert as to whether you're dealing with the immune deficiency. So this is on the history part of it. And then certain other things, like simple things like, okay, I think I'll go to it after you put your investigation findings on that. Is that okay?
Yeah, I think listening to a story always gives you a lot of clue. You know, if you have to ask history right from birth, how when did the umbilical cord separate, right from that. So why would I ask about umbilical cord separation? Why is it relevant?
Ma'am, to rule out conditions like LAD, ma'am, leukocyte adhesion
LED.
defects.
Okay, very good. And if I want to, if a child is coming back to you with recurrent diarrhea and they are not able to, they're eating well, but they are not thriving, and you found cryptosporidium in the stool, what would you think of? HIV, if you think of inherited inborn errors of immunity, what is the hallmark condition? Because you have to categorize, this is the story for T cell defect, this is the story for B cell defect, this is the story for a phagocytic defect. And so when you look at these three broad groups, what is the typical pattern? Cryptosporidium comes in which group?
T cell defects.
T cell defect. Very good. So it's a hallmark infection if you have someone with hyper IgM syndrome, for example, or so you can have pneumocystis pneumonia, disseminated BCG, CMV, and cryptosporidium for T cell defect.
Okay.
The same child, if they had a B cell defect, I would find giardia in the stool. So they're having chronic giardiasis, which they can't get rid of. And B cell defect, what is the hallmark with regard to the time of presentation?
B cell defects presents little late, ma'am. Not during after 6 months of age, ma'am.
Very good. So it's after 6 months because till 6 months they have the maternal antibodies protecting them, and after that it's predominantly bacterial. So, for example, you won't see CMV pneumonia or pneumocystis pneumonia in a baby with a B cell defect. So, bacterial infections is what they cannot fight. So, supposing you see a child with phagocytic defect, what would be the hallmark history?
Phagocytic defects presents with recurrent deep-seated abscesses, ma'am.
Okay, so that is LED. So the difference between LAD and CGD is LAD usually presents early, they are infants, and the deep-seated abscess, what is the main clue for you that this is something odd, something out of the way? What is the main clue about the abscess?
Abscesses in unusual locations like liver. Like,
Okay. So the unusual thing is they don't form pus. Because if you have leukocyte adhesion defect, the neutrophils are not able to go into the site of infection. So they form infections and they only gather serosanguinous fluid. So to form pus, you need neutrophils there. So they drain serosanguinous fluid. They are forming deep ulcers in the perianal area, in the skin. So then that is the hallmark of LAD. Whereas CGD is also a phagocytic defect. They phagocytose the bacteria but can't get rid of it. So they form granulomas. So if you have granulomatous adenitis and infections with staph and aspergillus, think of CGD. Deep abscesses, as you rightly said, forming serosanguinous fluid rather than pus, think of LAD. So just by listening to the story, you can say you have a T cell defect, you have a B cell defect, you have a phagocytic defect, and then you do your investigations to prove what is right and what is wrong. Okay, please proceed.
On general examination, the child is conscious, oriented, afebrile, hydration good, no pallor, icterus, clubbing, cyanosis or edema, bilateral multiple cervical lymph nodes palpable, largest being 2.5 cross 2.5 centimeter, which is mobile, non-tender, firm in consistency, skin over the node pinchable, no scars or sinuses. Bilateral axillary nodes palpable, largest measuring 1.5 into 1.5 centimeter, with same features as cervical nodes. Vital signs: heart rate 90 per minute, respiratory 20 per minute, pulses equally felt in all peripheral areas, BP 100/60, 50th to 90th centile, and saturation is 99%. On respiratory system examination, inspection, trachea appears to be in midline, apical impulse felt in left with intercostal space medial to midclavicular line. Chest wall appears symmetrical, chest wall movements normal, no retractions, no intercostal fullness, scars or sinuses. Tracheal position confirmed, and on palpation, tracheal position confirmed, apical impulse position confirmed, chest expansion equal on both sides, no tenderness or crepitus, vocal fremitus equal. On percussion, the hyperresonance was felt on left side of the lung. On auscultation, bilateral vesicular breath sounds here, air entry reduced in left side and monophonic wheeze was present, and vocal resonance was equal. Other system examination, CVS S1, S2 here, no murmur, abdomen, soft, non-tender, no organomegaly, central nervous system, no focal neurological deficit. Examination summary, ma'am. 9-year-old female child, third born of non-consanguineous marriage, first two siblings normal, normal perinatal transition, history of swelling in the left axilla at 4 months of age. Now complaints of fever, cough and cold for 2 weeks and significant weight loss. Family history of pulmonary TB in both the parents and the significant contact present. The child is thin and left-sided air entry reduced with monophonic wheeze. My provisional diagnosis based on the above history and findings is a case of lower respiratory tract infection, probably due to tuberculous etiology. Shall I proceed, ma'am? Management.
One minute. Let me. See, there are several findings you have to explain.
Okay, sir.
One, you have said that the breath sounds are decreased.
Okay.
In fact, I strongly object to your use of a term called air entry. Air entry is only for people in the ICU who don't have a stethoscope and who never use. No, in the intensive care only, you should talk about air entry.
Okay,
I think outside the intensive care, you should use the term breath sounds rather than air entry. Please stop using the term air entry in a very stable patient. That's one. In fact, Dr. Piyush Gupta, I remember, he wrote a letter in Indian Pediatrics that the sickness of PGs mentioning air entry instead of breath sound should go. It is there in Indian Pediatrics website. You can go in the past issues. That's one. Second, you have said there is a monophonic wheeze, and you have said air entry is reduced, and you have said hyperresonance. What is your interpretation? Is your interpretation lower respiratory infection when you find findings like this? What is the pathology? What is the pathology that you think is happening in the lung? This three finding, you put it in red.
Yes, sir.
Hyperresonance, 1 minute. Hyperresonance on one side, reduced breath sounds on the same side, and a monophonic wheeze.
Yes,
and
sir.
you are concluding it's lower respiratory infection. How does lower respiratory infection cause this finding? I'm not able to understand. Sorry for stopping. This may not be related to what you call PID, but it's clinical pediatrics.
Sir,
What is your
basically-
interpretation of this finding? Where is the anatomical lesion? What is the pathology?
Sir,
Anybody
with
can put in
history
the
of
chat
fever,
box.
with cough and cold, and with
Does tuberculosis cause cold?
sorry, with history of fever and cough, sir.
Thank you.
Okay,
I think omit that cold. Cold
Okay.
is never caused by tuberculosis.
okay, sir.
Okay, right. Unless rarely you have somebody who has got an upper respiratory tuberculosis, which is very, very unusual. Okay, right.
Okay.
That's one. Second, what you said, lower respiratory infection, probably tuberculosis. What is the pathology and anatomy? Where is the lesion? What is the pathology? Can anybody put in the chat box? In fact, shall I tell you what I mean, if these findings are right, you said trachea is okay, there is no mediastinal shift. Hyperresonance on percussion will occur only when there are two conditions, or maybe three conditions. One, an air leak, pneumothorax.
Okay.
Second, in asthma or any lung which is hyperinflated or emphysema at the chest. Third is very rarely, a stomach herniating into the lung, and if the stomach is empty, you can get hyperresonance. Okay, that also is not, that's very, very rare. Air leak from abdomen or something like that. So you have to think of only either a pneumothorax. The last condition is an obstructive emphysema. Obstructive emphysema. If you say monophonic wheeze is present, then air entry is reduced and hyperresonance is there. Your anatomical diagnosis is probably a bronchial luminal obstruction causing what is called ball wall obstruction.
Ball wall
Air is entering distally, but it's not going out.
Yes, sir.
Air trapping is occurring.
Yes, sir.
In which case, all the three findings you have put can be explained. In fact, don't mistake me. With this, in spite of history of tuberculosis, the first diagnosis I would have thought of is a foreign body.
Foreign bodies. Sir. Yes.
You are very biased for tuberculosis because this is immunodeficiency class. But I can tell you, this finding is very, very unusual. It can occur in tuberculosis. Granuloma in the bronchus can give rise to exactly a ball wall thrombus and a foreign body-like presentation. So I don't agree with your final diagnosis saying that this is lower respiratory infection and this is tuberculosis. It's beyond that.
Okay, sir.
It can be even a bronchial tumor which can cause obstructive emphysema like this. Okay, thank you. Over to the continuation of immunodeficiency. Please go ahead.
Okay, sir.
Raghavan,
Sir?
you are doing well.
No, don't get worried. You're doing wonderfully.
Yes,
You will know. You probably know more about immunodeficiency than what I know. Okay, thank you. Go ahead.
Okay, sir.
This discussion is to unearth, as Madam said, some lateral thinking.
Okay, sir.
So we have a pediatric stalwart, with hematology stalwarts. So both of them are giving some inputs for you. See, if you go and approach a case next time, you will approach in that methodological way. That's all. You will directly not jump into the diagnosis. That's what we want.
Okay, sir.
Good. Please continue.
Okay. So we went ahead with our investigations. Investigation CBC was normal, including hemoglobin, total count, absolute neutrophil count, and absolute lymphocyte count. ESR was 88 millimeter, and RFT and LFT were normal, sir. And MAN2 was positive in this child with 18 mm induration. X-ray showed mediastinal adenopathy and left-sided overinflation. And FNAC of the cervical node, CBNAT was negative. RGJ of the child was negative. Bronchoscopy was done, and left bronchial extraluminal compression was found. Ball positive for Mycobacterium tuberculosis, rifampicin sensitive, sir. And child started on ATT according to weight band and discharged. So this is the X-ray of the child, sir, showing mediastinal widening and overinflation in the left side of the chest, sir.
Madam, any questions from?
Yeah, if you can go back, please, to the investigations. You had mentioned absolute neutrophil count and absolute lymphocyte count. So if you're looking at reports
Okay.
On as a ballpark number, what ANC and what ALC will make you sit up and think there is something wrong with this figure?
Ma'am, absolute neutrophil count less than 1500 denotes neutropenia, ma'am. And absolute lymphocyte count for this child less than 1000, it denotes reduced absolute lymphocyte count.
Yeah. I think having 1500 as the cutoff, as you rightly said, for newborn and 1000 ALC, because what we normally do is look at the total WBC count. But I think you are right in pointing out that always we have to look at both ANC and ALC. And if anything is less than 1500, look at it again. That ESR is high, probably we've put it down to tuberculosis and or an infection, and that's why the ESR is high. And it's correct that you went on to do the bronchoscopy and prove this is tuberculosis. But at this point, right at this point, when you did the investigation, did you think that there was this child could have an immune deficiency because at 4 months age there was a history and now there is a history, or did you think it was only because of all the exposure, contact history, and overcrowding and malnutrition at this point?
Ma'am, we thought it at this point, we thought it was due to a contact and overcrowding, ma'am. Not
Oh,
due to genetic factors, it was due to these factors, we thought, ma'am.
fair enough. Yeah.
On follow-up, after 2 months of ATT, the X-ray was done and showed similar features, and there was no expected weight gain, ma'am, and no improvement in appetite. After 5 months of ATT, the child had hemoptysis and cough, and there was also no improvement in appetite, and there was weight loss, ma'am. At that point of time, when we did the X-ray showed miliary mottling appearance, and the CT scan also showed extensive involvement of the lungs, ma'am. So at that point of time, after 5 months of completing the ATT and with no expected response, these were the questions that were pondering around our mind. So first, is it TB? Yes, it was microbiologically confirmed. The drug dosage, compliance, and vomiting issues were addressed, and it was good. Drug resistance, no contact, and case both were rifampicin positive, rifampicin sensitive, and there was no known comorbidities for this child. The HIV was negative, LSSA and IG profile were normal. For considering paradoxical reaction, there was no initial improvement in this child, and there was no any associated malignancy, and pharmacokinetic studies were normal, ma'am. So on top of this, the child didn't have a proper expected improvement. So we proceeded with genetic testing, ma'am.
Wait, we'll discuss the differential diagnosis.
If you can go back, please, and tell us whenever you're at this point, because she didn't respond, you thought, since you have ruled out all the other things,
Yes.
does she have an underlying immune deficiency? So
Yes.
you have done lymphocyte subset analysis. So in a lymphocyte subset analysis, what are you looking for generally?
Ma'am, lymphocyte subset analysis, we are looking for T lymphocytes and B lymphocytes, ma'am, based on the markers like CD3, CD19, etc., ma'am.
So I think in a comprehensive manner, if you want to think about it, your ALC was normal, ANC was normal,
Yes.
and you have a child who's now come up to their 9th birthday. I'm just asking, is it likely to be a severe combined immune deficiency?
No, ma'am.
Unlikely, because they usually don't go past infancy.
Yes, ma'am.
So, if at all we had this discussion about recurrent tuberculosis,
Okay.
I would have put them under the group of chronic granulomatous disease. And by just doing lymphocyte subset analysis and immunoglobulin profile, you're not completing your basic workup of a primary immune deficiency or an
Yes.
IEI. What would have completed this is a
Big-
dihydrorhodamine test.
Yes.
So if I'm looking for how the immune system is working, definitely HIV on top of the list, a CBC to find out what is ALC, what is ANC. And as Raghav rightly pointed out, you want to look at both the neutrophils and lymphocytes. So lymphocytes, the total lymphocytes are CD3. And always look at the absolute numbers. They give percentages. Don't look at the percentage. And are the absolute numbers? We have normal established ranges right from fetal age to the elderly. So as early as 18 to 20 weeks, what is normal for that age? Because remember, we have a higher lymphocyte count until our third birthday, and after that, the neutrophils become higher. Out of the CD3, half should be CD4 and half should be CD8. So the lymphocytes go into the thymus, get educated, and then they come out, and then they decide I'm going to be either helper or cytotoxic. So CD4, CD8, the number should be equal to what is the total CD3. CD19 is going to tell you how many B lymphocytes. And CD16 and 56 are going to tell you about the natural killer cells. So normally we do only CD56. So total CD3, out of which how much is CD4, CD8, CD19 and CD56. So this will tell us what is the T cell component, what is the B cell component, and what is the natural killer cell component, and the immunoglobulin profile. What do you think is the commonest immunoglobulin profile we miss doing? In most
Now,
of
what
the
is the
packages, yeah.
no, what is it that you do first? Tell us. What are the immunoglobulin levels that you detect? Then you will know what you missed.
Uh, we will do IgM, IgG, and IgE, ma'am. And also IgM.
IG. So normally what is done is IgG, IgA, IgM in most of the packages. So what we miss usually is IgE. And IgE, children with IgE can also present to you with problems. So what kind of history will they come to you with? Somebody with IgE problem.
Hyper IgE syndrome will present with recurrent itchy dermatitis, ma'am. And they may also present with dysphagia and recurrent pulmonary infections, ma'am.
So hyper IgE syndrome used to be called job syndrome. So they had those multiple pustular lesions all over their body. So two misnomers in this immune deficiency group. One is hyper IgE syndrome, which we think, hey, you must be an antibody defect. So this is not an antibody defect, but it's actually predominantly a phagocytic defect. So bacteria they can't get rid of. And as you rightly said, sinopulmonary infection and skin pustules and hyper IgM syndrome. In which group will you put them, as T cell, B cell, or phagocytic?
Hyper IgM B cell defects, ma'am.
Okay, so that is again a misnomer. Hyper IgM classic is a T cell defect. So they are the ones that present with cryptosporidium diarrhea, pneumocystis pneumonia. So if you have someone with a skid profile, but they are 2 years old, 3 years old, and they've presented to you with pneumocystis pneumonia, think of hyper IgM syndrome because they can drag along for a little bit longer. If you have someone who got a B cell type story, but they are now 7 years, 8 years, but they've come with recurrent bacterial infections, then they, instead of X-linked A gamma globulinemia, you will think of a common variable immune deficiency. And remember that these can present with autoimmunity as well. So if you have an ITP child who's not responding to most of the things you've done, think of common variable immune deficiency. And a phagocytic disorder, atypical infection. So supposing you've done the bronchoscopy now and you found Burkholderia or Acinetobacter or Strenotrophomonas, for instance, then I would go more towards chronic granulomatous disease. Okay. Errol, you wanted to say something?
I think you've done it for me. The other thing that Revati didn't say is the complement deficiency. I think that she just avoided for now. Okay.
Yeah, so complements actually they don't present to us. They like
Mm.
nephrologists
Rheumatology.
no, mostly
Early
we go to
onset of
nephrology or
SLE.
yeah. So the only complement deficiencies that present to us are those who have recurrent meningitis. So very rare for complement deficiencies to present to us. Yeah.
Sir, your points on this differential diagnosis, anything to add, sir?
Hello?
Yes,
Hello?
Yes, sir.
Yeah. 2 or 3 comments. One, for reasons poorly understood, and in fact, I have asked this question to experts like Revati Raj. In India, if you look at the data that is available in our regarding immunodeficiency in pediatrics, there hardly any data in India about complement deficiency. I don't know the reason, but even in the largest series from Delhi, Chandigarh, everywhere, they hardly report any complement deficiency. It is probably underdiagnosed. That is one. Second, they say, of course, Dr. Ravitraj would add, if I'm not correct, they say one of the reasons why complement deficiency is often undiagnosed is that the CH50, which is used as a screening test, the test is not properly done in most labs. This is what many immunologists tell me. I don't know. That is one. Second, this chronic granulomatous disease is one disease which there is one primary immunodeficiency you should think of at any age. That's a great difference between chronic granulomatous disease and all other primary immunodeficiencies. There is no upper age limit for chronic granulomatous disease. There are, I have come across New England Journal case records where they describe CGD in a 40-year-old man. So all this has been published in literature. Unlike the IgA, IgG, IgE, and IgM, etc., CGD can occur at any age. And also, PGs must remember, in fact, we used to ask one quiz question, which is the most common immunodeficiency in the world? Can anybody put in the chat box? Most common primary immunodeficiency.
Sir, can I tell, sir?
Yeah, the most common one is actually IgA deficiency, not antibody deficiency. IgA is supposed to be the most common immunodeficiency, and we get away with it because most children with IgA just lead a normal life. Okay, and finally, in tuberculosis, you find something like this. And incidentally, if you happen to do a TB quantiferon test, which nowadays, in fact, now Manto is out and CTB test is going to be introduced by the ICMR across the country, where it is already being done for above 12 years in Mumbai and other places. It's going to be introduced by Serum Institute across the country. We won't be doing Manto at all. The other screening test for infection, tuberculosis infection, is gamma interferon, that is your TB quantiferon gold, which can paradoxically be negative in children with MSMD. That's one clue. If you have a culture proven or a smear proven or a CBNAT proven tuberculosis, and if you find your quantiferon TB gold test is negative, that could be a pointer to the presence of MSMD. Okay, thank you. Please go ahead.
Okay. So this child with a previous history of BCG adenopathy and parents with tuberculosis and other siblings normal with suboptimal response to proper treatment. So we pointed towards a genetic cause, and the genetic report came to be positive for IL-12 receptor B1 mutation, which is likely pathogenic, sir. So this is the final diagnosis. This disseminated mycobacterial infection due to Mendelian susceptibility to mycobacterial diseases. The deficiency is IL-12 receptor B1 deficiency, sir. The child was continued on ATT along with levofloxacin. On follow-up, child is doing better, gaining weight, and her appetite is better, and no further hemoptysis. Discussion.
So the take-home message is that we need to think very carefully. If a child is coming with recurrent tuberculosis, we have to ask ourselves the question, if, as Dr. SBS said, do they have drug-resistant tuberculosis, or they're not complying with their treatment, or are they immune deficient? And for the third component, sometimes on the surface, all the basic immune deficiency workup is all normal. CBC is normal, and the TNB markers are normal, immunoglobulins are normal. But then you find that they actually have an underlying immune deficiency like MSMD. So, like that, we have also been caught very many times. So we had this baby who presented to us at 9 months of age. At the age of 2 months, he had meningitis, and they had cultured Klebsiella from the CSF. He had 40 days antibiotics, and he got better. At the age of 5 months, he had another episode of meningitis, Klebsiella meningitis. Then he comes to us at 9 months with a pneumonia. TNB markers are bang normal, CBC is normal, immunoglobulins are normal. How will I suspect that this baby has something wrong with him? Is there any other way? I mean, I knew there's something wrong, so how can I prove? Would you have done immune deficiency workup, or what would you do?
So we would have proceeded with immune deficiency workup.
Yeah. So he turned out to be a rare type of immune deficiency called DOC8 defect, hyper IgE spectrum. So not all hyper IgE will present with high IgE because they're still infants. So that's what I'm trying to say. He's come with recurrent bacterial meningitis. So another baby, similar 9 months of age, come to us for evaluation of neutropenia, severe neutropenia. ANC is only 57. So, which kind of immune deficiency which would present with severe neutropenia, do you think?
Cyclical neutropenia syndromes, ma'am.
But they all are not at the moment put under the immune deficiency spectrum. In all these classic T cell defect, B cell defect, and phagocytic, I'm trying to ask you to think if they present with an infant who's presenting with neutropenia. So here hyper IgM. So sometimes it's hyper IgM, but they present very early on with neutropenia. So same, if the neutropenia is in a much older child, or thrombocytopenia or autoimmune hemolytic anemia, and we've given 7-day course of steroids, and with that the child has come with disseminated varicella. So here also we have to think of an immune deficiency. Some abnormal reaction to a drug that you would normally use for ITP, you would have used steroids. So I'm just saying that there are things from the history itself, we know that there's something wrong with them. If a child has come covered in viral warts, what would you think of? Which is the hallmark immune deficiency?
In hyper IgE syndrome also we can get
Hyper IgE. That's absolutely right. If they're covered in warts. We once transplanted a child with hyper IgE, and after his bone marrow transplant, all those warts just fell. He couldn't believe looking at his face that all his life he was covered in warts and everything became clear. Okay, thanks.
So discussion. Macrophages infected with mycobacterium produce IL-12. This IL-12 activates the T cells and NK cells that produce interferon gamma. Interferon gamma leads to TNF alpha production, and this interferon gamma activates and directs macrophages against Mycobacterium tuberculosis. Any deficiencies in this pathway may lead to abnormal response to mycobacteria. And these are the certain proteins that are involved in the pathogenesis of MSMD. So MSMD is defects predominantly in the interleukin-12 interferon gamma axis. It is due to either production or action of interleukin-12. Since 1996, 9 MSMD causing gene, including 7 autosomal and 2 X-linked, have been discovered. These disorders impair the production of interleukin or the response to interleukin and interferon gamma. MSMD designation does not recapitulate all the clinical features, as patients are also prone to salmonellosis, candidiasis, tuberculosis, and more rare organisms. So this IL-12 receptor B1 deficiency comes under IMD30. This is the most common form of susceptibility to mycobacterial disease. Activated T and natural killer lymphocytes do not express the IL-12 receptor B1 on their cells, and if they express, it is non-functional. So it lacks the response to interleukin-12 and interleukin-23. BCG disease and salmonellosis are the most frequent infections. So wide range of spectrum could result in multiple diseases along the T helper 1 cells lineage. Since it does not involve the T helper 2 line, immunoglobulin profile LSSA are essentially normal. These children requires longer duration of treatment with multiple antibiotics. Antituberculous therapy, macrolides and quinolines may be required for these children. In case of limited response or no response, interferon gamma therapy has been tried, and stem cell therapy has also been tried for these children. So our child presented so lately. This may be explainable due to variable penetrance that is seen in IMD30. And on probing further, we had found an history of oral candidiasis in this child. So learning points, approach to non-responding TB, confirmation by bacteriological confirmation, and dose, the compliance of the treatment, ruling out the comorbid conditions and paradoxical reactions and pharmacokinetic studies. In a case of atypical presentation and response to MTB, genetic studies could be considered suspecting MSMD. MSMD requires longer duration of treatment and drug combinations. Interferon gamma and stem cell therapy are under consideration. Thank you.
That was lovely, actually, the case, the way it was presented, and the learning points also are absolutely spot on. Um, uh, if I may ask Dr. SBS, if you saw 100 children with tuberculosis, I'm sure you see a lot. In whom would you think and investigate for immune deficiency?
Yeah. Can you stop sharing, doctor?
Yes, sir.
Yeah. That was a very nice presentation. Of course, Dr. Revati Raj had brought out all the important points. Responding to her question, as a general pediatrician, what I have learned over 4 decades, nowadays workup for immunodeficiency has become like reading a horoscope. When you start looking for a bride or bridegroom, right? So our suspicion for immunodeficiency, the threshold has considerably come down. I'm sure you would agree, thanks to experts like you. We general pediatricians have now started suspecting a diagnosed immunodeficiency pretty early. That's one. Two, Dr. Andrew Bush, a British pediatric pulmonologist, many PGs might be knowing. You can go put his name, you will find 500 articles on respirology. Okay. He gives a very nice mnemonic, which is extremely useful for a general pediatrician like me. The mnemonic he uses is SPUR, S-P-U-R. Severe, persistent, unusual, recurrent. That is any severe infection. For example, liver abscess, lung abscess, brain abscess. I don't think there is any question. You have to investigate. Persistent, oral thrush going on for 2 weeks. Any infant over 3 or 4 months, I wouldn't keep quiet. Unusual, pneumocystis, Burkhardia, Stenotripomonas, MRSA. I'll start thinking of immunodeficiency. And the last is the recurrent, as in this case, recurrent TB, recurrent typhoid, recurrent Shigella, recurrent osteomyelitis, etc. This mnemonic is very, very useful. And third important point, there are so many algorithms for suspecting a diagnosis of immunodeficiency. I think such algorithms, I'm afraid a general pediatrician cannot use it effectively. There are 3 things a general pediatrician should remember and start suspecting immunodeficiency. 1, any child with failure to thrive, even if there is no infection, please start suspecting. You may not investigate, please start suspecting. 2, any family history, unexplained death, they will say, child at 1 year went to this hospital. They said the child had brain fever, pneumonia, died. 1 year, 2. Why should the child die? Any family history. Third, very unusual. Some of the Western journals are quoting this more frequently. I'm sure Dr. Revathi Raj would agree with me. Even 1 course of IV antibiotic therapy to any child, I'm quoting it. Any receipt of IV antibiotic for a proper indication. IV antibiotic for rotaviral diarrhea is not a proper indication. Okay, any receipt of IV antibiotic course is an indication for you to start suspecting immunodeficiency. So if any of this is there, you have to suspect. And to respond to Dr. Revathi Raj's question on immunodeficiency and tuberculosis, of course, we all know that in the NTEP program, HIV screening is a must for all tuberculosis. That is basic. But for all other tuberculosis, we don't do immunodeficiency screening. Like I had put in the algorithm, anybody who is behaving unusually, yes, we investigate for tuberculosis. Non-responding infection, tuberculosis infection is an indication. We don't do it routinely. But if we start suspecting based on the SPUR criteria, based on clinical data, definitely we start investigating for immunodeficiency. And, when we publish in Indian Pediatrics, our series of immunodeficiency, the largest numbers were phagocyte defects. This is quite in contrast to the Western data. Western data suggests more of T and B cell defect. But in India, I don't know, Dr. Revathi Raj would add to it. The most common group of disorders which cause primary deficiency belongs to the phagocyte diseases, and very few complement defects are reported. And I have seen 1 congenital tuberculosis which ultimately turned out to be immunodeficiency and died. That's a very rare thing. And we also have a boy who's still alive. He has a gamma interferon receptor defect. He published in Indian Journal of Pediatrics. He came with recurrent tuberculosis of the tuberculosis osteomyelitis, tuberculosis parotitis, tuberculosis pneumonia, everything he had. Of course, this was 15 years back. We sent the samples to Casanova in France and proved it genetically. Of course, we did not treat him with gamma interferon because he had a receptor defect which won't respond. He is doing very well. He's now an adolescent boy. He's being followed up CMC. He's on azithromycin prophylaxis and he's doing extremely well without tuberculosis. Over to Dr. Revati Raj for her final comments.
I think, thank you for your comments. The main thing is, you said that about algorithms, and for me, Jeffrey Model Foundation and the information they've put out on the net, I think is something that every pediatrician should read, because all mothers will come to us and say, my child is getting recurrent infections, but we can't be testing every child because they've had 4 or 5 colds a year, or they're falling ill, or they're looking too weak. So Jeffrey Modell was a little boy who died of immune deficiency, and before he passed away, he was the original bubble baby. And the parents who are millionaires, before he passed away, he said, we must do something. And what they decided is that they will raise awareness, and they worked tirelessly all through their lives to raise awareness. And I, in my own lifetime, I've seen awareness for immune deficiency through IAP and the Indian Society of Primary Immune Deficiency. We are picking up a lot, because what the mind does not know, the eyes won't see. So since we are aware of it and we are talking about it, and through forums like this, people are aware that this is something unusual, I have to test. And they've got the child tested and found that they have an immune deficiency, which eventually results in survival. And we did a multi-center study of primary immune deficiency and transplants for primary immune deficiency. And the time of 2016, before 2016 and after 2016, such a big difference in outcomes. It was less than 10% before that, because we didn't have gene mutation universal access like we have now. Gene mutation testing, HLA typing, more than 140 transplant centers across India. So all of that was not there. But after 2016, supportive care, awareness, and access to transplant, government sponsorship for transplant, everything has increased. So I think it is our duty for to first diagnose, because if they're not diagnosed, we've seen so many families lose multiple children. And so we definitely should not be in that stage. So I just want to ask Ariel, sometimes like today, I did a consultation for a child online who is on the ventilator and has been diagnosed to have MHC class 2 deficiency. I think when they come advanced like this and when it's too late, what would you do in such situation for counseling the families, Erin?
It's a very difficult question for me to answer. Anyway, first we have to get a diagnosis, particularly if this is the first child. So if they're planning for the next also. So once we get a diagnosis, the only way is we can walk through them through the final pathway, and then probably sit with them and talk about what we can do and how we can take it forward. If it is the first child, we can talk to them about prenatal counseling of the second. But during this process, I would probably just stand with the family.
Yeah, I think, yeah, you're right. But if there is something that sometimes we forget because the index child is too sick, at least store their DNA, because only if we have some DNA to work on and find out this is the mutation of the index child, can we provide prenatal diagnosis for their next baby. So that I think is very important, so that they're not losing another child to the same illness. So that's something that always, at least we can store the DNA, because they may not be in a position to talk about genetic diagnosis counseling, but we can call them back for later if we have the DNA sample. And most labs now have access to DNA storage. So that's something in critically ill children. And if you've diagnosed someone with an immune deficiency, don't try to stabilize the child completely, because they have an immune defect. So you can't make them 100% all right, because most of us feel after the baby is better, we will initiate referral. So if we do that, it may be too late for the child. So as soon as you know that this is an immune deficient child, then send them to a center where they will get a choice of whether to do a transplant or not. Because when they've not been given the choice, they feel bad if they had been told earlier, or if someone's guided them earlier, because now access to care in our country is it's always an issue, but it's something that can be overcome. And we shouldn't be making decisions for families, especially the most important feedback we get from pediatricians is that this is the only child. They don't have a brother or sister, so a BMT cannot be done. And there are so many advances these days that we can do an unrelated transplant or a half match parent as a donor, which is called haploidentical transplant. So many advances are there. So initiate the referral so that they get information to make the decision.
There's one question, Revati. In this child, will you advise a bone marrow transplant in this child that
So we have done transplants for interleukin 12 deficiency, as Dr. SBS pointed out. So Dr. Casanova and most of the Western centers would keep these patients on gamma interferon injections, but immunokine is very expensive, and continuing that long term is really difficult. And in our country, eventually they will get a drug resistant tuberculosis, because first time it will be sensitive, second time sensitive, third time sensitive, and eventually it will become drug resistant. So we have transplanted children with interleukin 12 receptor, but even MSMD, out of this group, they are not all homogeneous. The gamma interferon receptor 1 defect is particularly prone to graft rejection. So we have to look at each of the gene mutation and plan their transplant differently. So we have learned so much from these children. And Dr. Casanova's landmark paper, How Do We Fight Tuberculosis? And it's taught us so much about the immune system, because it's led to so many discoveries, how we've evolved and how we've fight. I mean, you already saw how many genes are identified of mutations that result in MSMD. It's not one or two. Raghav, you want to ask anything? So this one, would I transplant? I would definitely offer it to them, because when they are stable, if they have the transplant, they do better than if we have to take them up with active tuberculosis, or once they've developed drug-resistant tuberculosis.
Meanwhile, this
and the one
started on itraconazole prophylaxis and probably even azithromycin prophylaxis to prevent, some notorious infections like Yersinia, Shigella, Salmonella, and fungal infections. They are notorious to have. In addition to ATT, you should be giving antifungal as well as atypical mycobacterial infection prophylaxis for this child with azithromycin. Otherwise, new infections can develop. Incidentally, there have been one or two papers which have tried to validate the Jeffrey model criteria, and they have come out with statements that what I said, 3, failure to thrive, IV antibiotic, and family history is probably, it has got better sensitivity and specificity than the 10-point model.
Sure. Yeah.
That's why I there. There in one of the articles on primary in archives of disease, how to investigate for immunity. Beautiful article, which gives you a statement that it's not necessary to use the Jeffrey model. You can use these 3 criteria, and your index of suspicion will be high. In fact, India is planning to eradicate tuberculosis by another at least 5 years. And if you eradicate it, once you eradicate, if somebody has tuberculosis, I think straight away I would start investigating and probably refer to Revati Raj to rule out immunodeficiency. That's the way we are moving forward. We never used to think of these diseases because we had no diagnostic facilities. We never thought of it. Now we start looking for it, it is there. And
if we don't do it, they'll go to ChatGPT. So we
correct.
better be aware.
Correct. And nowadays, treatment options are available. Immunoglobulin is saving so many lives. Prophylactic agents are saving lives. And of course, your stem cell transplant has saved so many lives. In fact, incidentally, Dr. Revathi perhaps would have done the largest number of pediatric bone marrow transplants in India and saved so many lives. So we should diagnose early and refer early. And the point that she said is very, very, very valid. You can't stabilize the patient. Stabilization is only with bone marrow transplant, not with medications.
This child
One more
after
sug-
GP, at least if they've had 6 to 9 months of ATT, and if we get a PET to say that there's no active TB, that's when we'll take up. Yeah. Ariel, sorry.
No. Sir, you being one of the advisory board for vaccinology, I was just thinking if BCG at birth for most of them, even in the primary health center. So we can have a small checklist with which they can take and before giving the BCG, in which case even the few cases that we get into severe forms of BCG-induced adenitis, we can save them.
Yeah, that's a good one, Dr. Ariel, but I think we should move beyond that. I think people like Dr. Revathi should shake it up. Now we have started neonatal thyroid screening. Okay, we have started screening for neonatal inborn errors and metabolism. I think in 10 years, I'm sure in India, we'll be doing primary immunodeficiency workup from right from the newborn period. I'm sure we would follow the Western model and not lose lives. It's very sad to see. In fact, I know even one of my patients in whom we diagnosed SCID after the child developed a big BCG adenitis and abscess. The child died of disseminated tuberculosis, BCGosis, rather than the primary immunodeficiency per se. So, such cases are avoidable. I don't think screening questionnaires will solve the problem. Screening test only will solve the problem. Because screening questionnaires will reduce the number of cases. I agree with you. Sibling death, and unknown cause of death in the family. Then you can withhold, you can do investigations, and how many of them can afford? That's the problem. Now, with more government centers coming up with screening for genetic disorders, I think we should progressively start doing neonatal screening and postpone the BCG to 1 month with more reduction in tuberculosis. This would be a good policy.
I want to make a comment that you had said that in Western countries they are seeing more of SCID, whereas we are seeing more CGD. It's because a lot of them don't get diagnosed at all and they come under infant mortality statistics. If we properly diagnose, we will have enough and more SCIDs because they don't get to the a center where they can be diagnosed, most of them. So at one meeting, we had transplant outcomes for SCID and non-SCID IEIs. And all of the data from the US and UK and Europe, newborn baby screening for SCID, before they get their first infection, they're having a transplant, leading a normal life. Whereas ours, they come with polio, disseminated polio from the oral polio drops, the disseminated BCG. So it's a challenge. Some of them we've needed after a successful transplant, we needed to continue ATT for about 2 to 3 years to come get them back to normal. So I think newborn screening is the way to go forward for such disorders so that we can have better outcomes. And the most important thing is to have forums like this where we can teach younger people to think about immune deficiency. I think whenever something is out of the way, should I think of immune deficiency? What should I do? And also remember that the government now has the rare disease project where some of these families can get 55 lakhs money given to them for their treatment. So access to care, as I said, for rare diseases is actually better now.
In fact, I was surprised to read a paper about 2 years back in Journal of in Pediatrics, American Academy of Pediatrics Journal. 10% of those who had invasive pneumococcal disease, 10% had some primary immunodeficiency, I believe. So even in pneumonia, pneumococcus, I think we should start doing PID workup. I don't know. Whether it's somebody may say it is too much, but that's the way to look forward to.
Can I make a comment?
Yes, sir. You're welcome.
Yeah, even in undergraduate teaching, I think we should impart the importance, especially the SPUR and also the criteria. I think, because many of them, they practice as an MBBS doctors. Not everybody becomes pediatricians. I think this is very relevant to be introduced quite in the early curriculum. Yeah, because it's not very difficult. When they know serious, the SPUR is easy to think about it. And I think all the points have to be incorporated in the undergraduate curriculum. Whatever points you have mentioned, when to suspect and what are the easy ways of referring these patients to experts.
Yeah.
I hope I'm not made any.
No. What you said is absolutely right. What you said is absolutely right. In addition, I think one of the factors which leads to delayed diagnosis, Dr. Revathiraj, is because pediatricians look more at neutrophil counts. They don't look at lymphocyte counts with so much precision. And they miss lymphopenia. Neutropenia, they may not miss, but they miss lymphopenia, and that may be disaster. I'm sure you would have seen Dr. Revathiraj.
Yes, absolutely agree. ALC is equally important, and interpreting all these results. Speak to the lab person who's done it if you have queries. I think talking to whoever's done the test also helps. Yeah, and not to go by NBT, because it's one test that is a little bit old style, and a flow cytometry based dihydrorhodamine assay is much better screening test for CGD rather than NBT.
Okay. Dr. Ayler, your comments, ma'am?
I think it's all concise. Only thing, keep our eyes and ears open. But as you said, the mind will not think what the eyes will not see what the mind doesn't think. So any child, because as you said, the way forward. But till then, at least everybody before giving an BCG for all the postgraduates will just take a short history, because nowadays I don't find got a lot of importance given to history taking. It's all protocol driven, and so good history taking will save a life of a lot of people. As Sir said, you just wait, evaluate the child before you go ahead and give live vaccines.
You remember, Sir, Dr. SBS, that when Yeril and Dr. Sarla also were there at that time, Ramanan had come from the UK, and we had a whole series of awareness on HLH. And when dengue came, we were diagnosing the HLHs earlier, giving them steroids, IVIG, and mortality came down. Like that, I think we have to go on talking about immune deficiency and raising awareness, and only then we will know more about, because some of the immune deficiencies can present to other specialists. So a pediatric gastroenterologist, if they see someone with a lot of perianal fistula and inflammatory bowel disease in a 9-month-old baby, then we've diagnosed a condition called IL-10 defect and transplanted the baby who could never eat anything, and now he's thriving so beautifully. So as we know more about these disorders, we are discovering more immune deficiencies. And now there's an entire spectrum where there is autoinflammatory disorders and immune regulatory disorders. So many. So it's a world out there. So um, uh, uh, they can present to any specialist. So that's why we have to keep our eyes open. Yeah.
Any disease, we have to ask why, and keep on investigating. That's the way it has become. It's like reading a Jatakam, a horoscope.
As exam-oriented, this thing, postgraduate, I think we have to constantly, every alternate years or this thing, exam, one question should be there, when to suspect and how do you investigate. It's very important because most of them is oriented towards exam questions. I think if we have to make them aware of this, I think periodically these questions must be asked, especially about immunodeficiency, when to suspect, and how will you go about investigate.
Well said. Well said. Yes, Dr. Prasanna.
Yes, sir. Oh, what a discussion. I was just, there was pediatrics, immunodeficiency, pulmonology, infectious disease, everything was there. The complete Jugalbandi, sir. I can say excellent discussion. Excellent presentation by Dr. Radwan. Though your examiners are one examiner is fellow of Royal College of Pediatrics and another examiner is fellow of Royal College of Pathology. So they completely dissected. So in the exam, you'll be more, if such a case comes, you'll be more efficient now in handling. So our aim is to involve postgraduates, expose them, all the postgraduates from Chennai, various colleges, all the mentors, show how the examiners will be like. So you did a very good job. And if you are a practicing pediatrician, you had some message when to suspect and when to refer from the moderators. So I hope it was a wonderful discussion. Som Sundaram sir, a few words from you.
Yeah, so I second you, Prasanna. It was a 90-minute, as you told, it was a mix of immunology, pulmonology, infectious disease by the three specialists here and supported by Dr. our Srinivasan sir. So nice presentation, ma'am, and very useful to us also to, and as you told, what the mind does not know, the eyes can't see that. So that's the thing, like we should suspect immunodeficiency at the first instance. So thank you all for your sharing your expert knowledge in this forum. And definitely IAP, as I have shared in the group, and whatever your Anurag, your colleague has shared, I have shared it in the group. I hope this will be useful for the rest of the 800 members there in the group, ma'am. Thank you very much. And I think there is a question there in the Prasanna. There is a question there.
Is whole
By
exome sequencing by passing the immunological test.
I think both need to be done in parallel, Dr. Ramesh, because we can't directly do whole exome sequencing. We need functional assays. So, is the DHR positive or negative? So, it's the same debate people are having in Fanconi anemia. Should we do the mitomycin C stress cytogenetics? Can't I do whole exome sequencing directly? It is really needed to have functional assays to see how are the lymphocytes functioning, how are the neutrophils functioning, and the sequencing all in parallel. So it is important to have everything. And I want to thank IAP, CCB, and Yeril, my dear friend, for this opportunity on behalf of the Apollo Hospital team. And we really appreciate the fact that this was highlighted during the Immune Deficiency Awareness Week. Thank you so much.
So pleasure, madam. Sir,
Thank you.
You are there, sir? Singarvel, sir? Okay.
Sir is there?
I think he's not there.
Think it's not there.
No problem.
Just one comment, Prasanna.
Yes, sir.
If somebody cannot afford whole genome sequencing, you can send blood sample to National Institute of Immunohematology, Mumbai, where they do for 1,500 rupees complete P-cell, flow cytometry, and immunoglobulin assay, and also DHR. So 1,500 rupees they do it. Somebody, I mean, if you want to screen primarily for primary immunodeficiency, and if parents cannot afford whole genomic sequencing of 10,000 or 15,000, you can send a sample. They charge only 1,500 rupees. It can be done. I'm sure Dr. will know. Dr. Raviraj will know.
I will share this information with the group. with this, we'll come to the end. I will request all the postgraduates to join us for the next session. It will be on May last Tuesday, 27th of May. So we'll have another good session. And those who have missed, you can share to your friends our YouTube channel link so that they can watch this wonderful discussion again. Once again, thank our moderators. Yes, sir.
Yeah, before I thank, my special thanks to Prasanna. He has been working for the past 1 month to coordinate everyone and bring everyone for this stage. So thank you, Prasanna. So well done job for the past 4 months, and we'll continue the same for the next 8 months in enlightening the postgraduates, and our special thanks to our moderator spending his last Tuesday with us on this platform, sir. Thank you, SPS sir, for your inputs and suggestions and your valuable time with us, sir. Thank you very much.
Thank you, one and all.
Good night, all of you.
So with this,
Thank you.
Thank you, ma'am. Thank you. Yeah.
Thank you. Thank you.
Thank you so much.
Thank you.